My name is Caelan Taggart. I'm a cardiology research fellow in Edinburgh. I'm just going to give a quick talk today on developing a consensus for the assessment and management of patients with type 2 MI. Did I change this slide? There we go. That's just my funding from the British Heart Foundation. So, as we know, type 1 myocardial infarction has now got favourable outcomes with about 2/3 of patients alive at 5 years. There's good evidence-based guidelines and therapies from the AHA, ESC, etc., and many RCTs to inform and guide our care. Type 2 MI, on the other hand, has got extremely poor outcomes with only about 1/3 of patients alive at 5 years, and there's no guidelines on assessment and management or any RCTs to inform or guide our care. But more importantly, there's never been an effort made to gain consensus on how we should assess and manage these patients. Which brings us to our aim. So we decided to try and get a panel of experts together and develop consensus on assessment and management of these patients. So we decided to do this by doing a Delphi study. So you're probably asking, what's a Delphi study? It comes from the concept that the opinion of many is better than the opinion of one. And it basically is the circulation of a questionnaire to a panel of experts, deductive analysis, and recirculation until we can get agreement on a point, in this case, management recommendations. So just to kind of go through the study in more detail, how we did it. So we picked a panel by doing a systematic review of the literature, identifying clinicians with expertise in the area. We then circulated an open round and question and key themes in the condition, trying to get them to talk a bit about what we would do and what recommendations we could make. And then going on, then we made these recommendations into statements, and we assessed agreement on a Likert scale, 1 to 5. When 80% agreement was achieved, we put these forward for a recommendation, and when 80% disagreed, we put it in the bin. So, and when there wasn't any disagreement, we put this for one further round, and that way we can assess whether or not what we want to take forward. So we've done a systematic review of the literature in type 2 myocardial infarction and revealed 424 key articles in the last kind of 15 years, ever since it was first introduced. Once we removed what articles weren't pertaining to key original research in it, we ended up with around 150, and once we excluded repeats, editorials, etc., we ended up with kind of 114 key papers in this area. From these key papers, we identified 78 potential collaborators from 43 teams throughout the world, and we removed 10 who weren't clinicians, and we, from our steering panel, identified 5 more, leaving us with 73 potential collaborators to be contacted for our study. So we kind of had to have a think about what themes do we want to try and get to the bottom of in this condition. Very little is known about it, so I think it's very important that any patient with type 2 MI, the first kind of questions you're asking is, what's their coronary artery status? How do we assess for coronary disease and cardiac function? We want to know, should we be revascularizing these patients? What secondary prevention measures do we want to implement? What sort of risk stratification measures can we take? And a very important one, I think, is what the patients understand and what can we communicate to them about this condition. So from our first, we got 38 responders out of 67, I think. Actually, the emails worked. Generated about 80 pages of pure text just on discussion about it. And from this, we had 697 statements, which we narrowed down to 67 unique statements on management recommendations about this condition. So we've done an interim analysis of round 2. We still have to do round 3. It's still in progress at the moment. But from these 67 unique statements, we have reached agreement on 25 thus far. 40, there's still not agreement has been achieved, and 2, there was disagreement not to be carried forward. So just to kind of show you where we're agreeing here, where the panel, the expert panel is agreeing and where they're not agreeing, the green, as you can see, indicates agreement, orange doesn't. So there's no agreement on cardiac, how we assess for cardiac function. However, there's some good agreement on what secondary prevention measures we want to implement, such as aspirins and statins, and also on how we should risk stratify these patients as well. So I'm trying to make things maybe a wee bit interactive. So I know there's a broad range of specialties here today, but I would just encourage everyone to have a go. Can I have a raise of hands if you think that the current definition of type 2 should be reviewed? Yeah, so the expert panel mainly agreed, but again, there's about 30% of those who didn't, thought it's great, doesn't need to be changed. Another one is all patients with type 2 MI should have an echo. Does show of hands, who thinks that should happen? No? Interesting. Well, the panel thought mainly so, but again, I think they wanted more on a patient-to-patient basis. These are some other ones that we've got so far. So we wanted to find out what clinicians think if patients have a good understanding of this condition or not, and 100% disagreed. But you think that we would know what we're talking about here, and clinicians, we asked them, do we understand what we're talking about? And again, 100% disagreed that we don't know anything about type 2 myocardial infarction. So, yeah, that's to conclude. Really, I think the management at the moment really comes down to risk stratification, assessment for cardiac function and coronary status, and then the initiation of cardioprotective therapies. We think that the expert consensus on this may inform guidelines and aid in the trial designs, because there's no RCTs in this area, so it's all good information going forward. And I think also we need to do more work and qualitative work in the consensus from patients on what they understand about this condition, because we think that understanding is pretty poor at the moment. I'd just like to thank Dr. Amy Ferry, who helped me design this study, and our steering panel of Andrew, Professor Mills, Professor Tigas, and Lindell and Eggers from Sweden as well. Thank you.
Thank you. Thank you so much. Also, this last presentation is now open to the floor. Questions? Richard? Dr. Novak here.
Thank you. It's a very difficult topic, and we're trying to get some idea what this all means, and I understand that. The expert panel is a consensus of limited data, and it's almost an opinion thing. So I'm just curious that when you finally put this together, are you also going to report the dissenting minority opinion and why? Because if you don't, you're just giving the overall overview, which may or may not be right, and there may be some very good points in the dissenting opinions. I'm just wondering how you're going to handle all that, because you have bright people who have differences of opinion, and I don't know if you're going to present both sides of what the discussion was or just one side.
Yeah, so that's a really good question, and I think that's why we chose to use a Likert scale in the second round to kind of grade agreement, and we'll report each of the statements in the agreement on each using kind of a covariate kind of analysis, and that'll kind of show us, whether there's been really strong agreement or really poor agreement. And you'll see ones where there's not been great agreement that, yeah, there is a difference of opinion. We also gave all the collaborators a chance that even they're just selecting agree or disagree to make comments, which we carry on in the third round, and we're trying to adapt and change at each round to make it better as well.
Okay, just one last question. If not, thank you very much again.